Okay, we can go ahead and begin. Hello everyone, and welcome to today's webinar on the impact of communication skills training for providers, learnings from the UCSF Health Experience. Thank you for joining us. This webinar is hosted by the Academy of Communication and Healthcare. My name is Rachel Porch, and I'm the project coordinator here at the Academy. ACH is a nationally based nonprofit organization, and this webinar is our first in a special webinar series from ACH where communication training program leads from institutions will share their journey in implementing a skills training program at their home institution. If you're not an ACH member and would like to benefit from our recorded webinars, online membership community, as well as many other valuable benefits, we would like to invite you to join our organization. So feel free to visit our website. They're located at the bottom of the screen for more information. And as a quick housekeeping note, you're welcome to use the chat box on the right-hand side of the screen. We'll be taking questions at the end, so if you think of questions throughout the presentation or comments, feel free to type them there. And again, we'll leave time at the end to answer those questions. So moving forward, I'm pleased to begin my handover here to Dr. Diane Sliwicka with a short introduction. Dr. Diane Sliwicka is a hospitalist and clinical professor of medicine in the Division of Hospital Medicine at the University of California, San Francisco Medical Center. In her role as Chief Physician Experience Officer at UCSF Health, she has led provider experience efforts organizationally since 2014. This role includes measurements of the provider work experience as well as individual, local, and organizational efforts to improve well-being and the structural and systemic challenges for providers. Diane leads the UCSF Health Center for Enhancement of Communication and Healthcare, which provides relationship-centered communication skills training for providers. In addition, she is Executive Medical Director for Patient Experience with a focus on physician engagement. Dr. Sliwicka is also a faculty in training at ACH. So Diane, it is great to have you here, and without further ado, I will pass the presentation over to you.
Thank you so much for that lovely introduction. So I'm honored to be here. I just wanted to mention up front that I know many on the call may also be doing this work, and although I'll be sharing my experience here, I am very interested in opening dialogue with others who may also be doing this work in the future. In this presentation, I will aim to cover 4 things: the overview of our program, the outcomes that we have measured in implementation of our program, the lessons we've learned, and sustainability and next steps. So starting with how we structure our communication skills program, we have named this the UCSF Health Center for Enhancement of Communication in Healthcare. And I'll say that we are a university hospital located in San Francisco, so our program is really right now targeting our faculty clinicians, so physicians and advanced practice providers. We offer a foundational course, which is a day-long course called Enhancing Relationship-Centered Communication Skills, as well as shorter booster sessions, which apply similar skills to communication challenges. And then we also offer bedside coaching, one-to-one, and a book club on communication books. We have a group of, small but mighty group of amazing facilitators who are diverse in their clinical backgrounds in the sense that they come from many different specialties, including primary care, a surgical specialty of otolaryngology, head and neck surgery, hospital medicine, psychiatry, and dermatology. One of us is a physician assistant, and the rest are all physicians. And these folks have all been very extensively trained by the Academy of Communication and Healthcare with a 7-day training program, which focuses not only on the content to be delivered in the courses, but also, most importantly, on the facilitation skills. And I'll say that this group has become really the greatest champions of this program and the work, and have really become leaders across the organization in furthering the improvement of communication across our providers. Our program is is voluntary in participation. We do not mandate that our providers go through it. We use small group sizes to do these trainings, and the facilitator to participant ratio is about 2 facilitators per 12 participants to create the best kind of learning environment. We mix our learners in terms of the advanced practice providers and physicians. We do not include residents in the faculty level courses because of the hierarchy involved with learners and GME and students. But we do offer courses to our residents in different groups. The foundational course I mentioned is 8 hours, and we do provide CME for that to make it a little easier to swallow the time involved. And then the boosters are shorter, about 2 hours or less. And we do use the relationship-centered communication model that is described by the Academy of Communication in Healthcare. The courses are really built on a lot of interactive role-play time, very little didactic, only enough to share content and let people know what they're expected to do, but really the key learning comes from practicing saying the words. Another feature of our program is that we use learner cases, so we use some of our own examples cases, but really for the role play and the learning, people bring their own so that the course becomes relevant no matter what clinical background you come from or what you do. I have the words credible facilitators here in the sense that all of our people who are teaching this work are of the same clinician type as the learners that they are teaching, so they really do understand the work of being either a nurse practitioner or physician, and they've also gone through this advanced training so that they have the skill needed to facilitate. And then the proper amount of time, people often question whether you need 8 hours to do a course like our foundational course. And I'll say that we have experimented with doing shorter versions at many people's request for doing this as easily as possible. However, we find that our learners always ask for more role play time at the end of those shorter courses. And since role play is such an important part of the learning here, it does really warrant the time, and so I'd say that is a key feature of building any program, is to not have it be something that's kind of, oh, I looked at the content one time for an hour and now I'm going to go do it, but rather something where people get to practice the skills and get appropriate feedback. And then we've built in some follow-up, which I'll talk about at the end. So how have we measured, both how many people have gone through our program, what have their attitudes been about the program, and what have we found, as well as I would like to answer the question of how does this impact our scores in terms of patient satisfaction survey results. And I'll start with the beginning, which is just how many people have we trained. So in the first couple of years of the program where we put this data together, we had trained about 12% of all of our MD and advanced practice providers. And in addition, about 100 more with the microskills courses. In the top of our graph, you'll see the specialties that are most highly represented in our trainings, and important to point out that all of those areas have leaders who are deeply committed to the communication skills work, and I think there's a very close relationship between dedicated leaders and how many people go through your course if it is not mandatory. But a broad mix of different kinds of specialties represented. In terms of the attitudes, I think of the most interesting is people always wonder how will people feel about the amount of time it takes, and you'll find that the valuable use of time graph shows a very positive rating of whether the 8 hours was a valuable use of time in addition to all of the other characteristics measured here. And then we gather testimonials from the surveys we ask of people at the end of the course and ask them to reflect on what they thought before and after the course. So find things like comments here, such as before the course I thought that I know it all and some people were just going to be out of my reach. The communication skills were things people have versus do not. That my driving the agenda with patients was saving me time. And then after the course, now I know comments like, I have much more room for growth in dialogue and fully engaging at patient's level. With gentle persistence, focusing on patient's perspective, I can be a better provider. It's a time saver to elicit the patient's concerns. So kind of emphasizing this shift to, wow, this I can do this differently, and this actually helps me save time. And moving forward to our data, which specifically looking at patient satisfaction type data, I'll describe some of the data we looked at for the cohorts that have put many people through the course from their specialty, starting with anesthesiologists. So in this graph, you can see, and I'll pull up my arrow here, the trainings, there were 2 trainings done, a cohort, one group done as cohort 1, the second group done as cohort 2 at these time points. And there are 3 questions on the patient satisfaction survey that we ask about anesthesiologists. Did they prepare you well? Did they give explanations that you could understand? And would you recommend them? And you can see the trend over time to improving the scores from patients, and even in the following year, mostly sustaining or improving these scores. And the next question you might ask is, okay, well, you've got scores that are improving, and how do you know that it's really related to this course? And I'll say that for all of this data, we can't say for certain that the data that we're seeing in patient satisfaction is related to the course itself, but you'll see certainly a pattern. But what we did do to check whether our skills that we were teaching in the course were actually making it to the bedside was we did a study looking at what these anesthesiologists were doing 1 month prior to the course and then 1 month following the course itself. So intervention was that 1-day foundational course here. And we had a blinded observer watching for all of the skills that we teach in the course and rating the anesthesiologists on whether they did each skill not at all, whether they did it completely well, or whether they did something in between, for a total scale of 28 points. This group was also compared to a control group which did not do the course, so both control and intervention participants were observed in this blinded way. And what we found was that in the control group, the scores did go up a little bit from pre to post the course. So something else in the environment may have changed, or maybe just random that this changed. But in the group that did the course, a much more substantial improvement in their scores following the intervention, and those were statistically significant. For primary care, another audience of providers that we were very interested in improving, as they had some of the lower scores overall. And for this group, it's important to note that there was also coaching going on around the time of this by their clinical leader. And so the kind of what we see here also has a complement of coaching going on in the clinical setting in addition to the course training. But you can see that for the providers who did the course, there was an improvement from the 3 years prior to the 2 years after, and that was sustained over time. And if you compare that now in orange, so blue is the providers who did the course, and orange is all of primary care. As I mentioned, all of primary care was going through coaching at the bedside. But for the people who did the course, what you find is that before the intervention of taking the course, they were actually performing much lower than primary care providers overall at our institution. And after the course, they were the ones who were bringing up the score. So really an improvement among that specific group more than the others that hadn't done the course. This is dermatology, again, a trend over time of improvement as multiple smaller groups of providers went through over a period of a year or so. In gastroenterology, a similar pattern. And in hospital medicine, in this group, we had also observers doing team-based observations, so faculty getting trained, but then observers going into the clinical settings and actually watching teams and giving them feedback at least once per 2-week period during different parts of the year, so an emphasis on continuing attention to this in the clinical setting with improvement over time. And when we look at areas that haven't sent providers through the course, we are not seeing the same kinds of improvements. So here's just a couple really major clinical areas in our health system that are declining or not improving. And more important than scores, because I think everyone likes to know, is this impacting scores. And we do think that there is an impact here, but more important is that I think often people get, so attentive to the scores that they forget there's so much more to the impact of this work. And to me, here's a story of our physician assistant, Laura Kirk, who is one of our facilitators, telling a story about the impact for her and for a patient of implementing a skill that's taught in the course that is asking the patient what else when they are generating an agenda for the visit. So making sure that the patient has had a chance to tell the provider what's on their mind before they start the visit. And I'm going to go ahead and just play this for a couple minutes.
I've made it a habit of asking my new and follow-up patients in general otolaryngology what else when we first start discussing their list of concerns for the visit that day. And a patient of mine who I had seen once for a relatively unconcerning ear problem came back for a second visit. And I asked her, what else should we discuss today? And she paused and said, well, I actually have been concerned about this itching inside my nose, and I'm sure it's nothing, but maybe you could take a look. And I did, and did an endoscopy because there was a concerning appearance, and fast forward to a biopsy and receiving the news that she had intranasal melanoma. And I don't often have to deliver profoundly bad news to patients, but this was one of those cases where she has a rare condition with a very poor prognosis. So I was able to get her into our head and neck cancer division for further management. And after her surgery, I called her to check in to see how things were going. And she said, Laura, I have to thank you, because if you hadn't have asked me what else during my second visit with you about my ear, I would not have felt comfortable telling you that I had this nagging worry about my nose. And, that undid me. Asking her what else really changed our relationship, and it changed her course of care. And it's something that I'm going to keep doing.
So for those who couldn't hear the clip, it's Laura talking about asking what else, and a patient telling her kind of something that wasn't really intended to be the reason for the visit, of having kind of a itch in the nose, and it turning out to be a new diagnosis of melanoma that really both impacted the patient's course of care as well as Laura herself as a provider. And I think the potential of the impact here for providers to both provide better patient care through better communication skills, change the outcomes for patients, and feel more effective in their own work are all together, really the magic of this work, and why it's so powerful. So moving forward to lessons learned. A few things. I could probably talk about this for hours, but I picked about 4 things to emphasize here. The first being that improving communication skills reaps rewards for clinicians as much as patients. Another quote from Anna Meyer, another one of our facilitators, tried out a skill called ART with a consent for surgery, saying it went very well, confirmed by the parent when asked if he had more questions, stating that I had answered them all, that he felt so comfortable with me as the surgeon, and that the other doctors they had seen weren't like me and had never answered the questions they had or made them feel that they actually cared about his son. Wow. So again, this impact for providers, this kind of reward that providers get from knowing that they're helping patients and easing anxiety for patients during times that are very difficult is really important. Lesson 2, being patient-centered versus relationship-centered. The choice of this word relationship, I think, is incredibly important for the selling of this program, but also in how people think about what communication skills are. If you just go to physicians and start talking about let's improve communication and improve things for patients, many of you have probably already heard about the statistics of burnout among our physicians, and what they come back with is usually what about me? Like, what about that I'm drowning in my work here and I care so much about these patients and I can't actually deliver the kind of care that I want. And so talking about relationship and both the provider and the patient really helps value both parties, and it emphasizes the bidirectional nature of the communication, which role models kind of the point that communication is bidirectional and not just one person talking at another. And then really this helps to show the application of these skills beyond just clinical encounters, that this isn't really just about patients, that there are many more ways that these skills can be applied between people. The third lesson is about the use of data. So this is a picture of my daughter playing softball, my gratuitous family picture. Exactly nobody will wake up in the morning saying, I really want to go to work today and knock those HCAP scores out of the park. And we have to be very, very careful about how we talk about patient satisfaction data as it relates to the use of these skills, because people will get confused and think that we want them to improve the scores. And really the target is not the improvement of the scores. The target is improvement of patient outcomes, of patient understanding, of patients' kind of anxiety being lessened by what we bring to them in the encounter. And so it is important to use data that demonstrates that communication is associated with outcomes, and there are many examples of that, but using a lot of caution with how we use patient satisfaction scores, and we separate that completely from our communication program. It's not really connected or talked about in any way during the day when we teach these skills. And then the fourth lesson, which is kind of the potential for this kind of course or skills training to be to elicit eye rolling among your providers, either because they've been doing communication for a long time and they think they're doing it great, or because there's just a lot more important things to work on. So I think in order to really bring home the value of this for people, we really pull out things that providers don't think about when they first hear the word communication, and it's things like, how do we communicate when we don't have a lot of time? Like, how do you build relationship when you're only seeing someone for 10 minutes before their surgery and you're the anesthesiologist? How do you help navigate conflict between doing the right thing and what patients want? So all those patients that are asking for MRIs they don't need, or opiates that they shouldn't really be escalating, how do you navigate those conversations and still maintain your relationships with your patients? Interpersonal conflict, so kind of thinking to how much more broadly these skills can transfer to other things, like what if I'm a leader and I have to work with people on my team or with learners, or the most fun is when we start talking about how these apply at home with friendships, with our families. These skills are really transferable, and when people start applying it to all of those things, they really dig into the value of this and start to enjoy the work. So kind of moving on to sustaining and next steps, I think there are important features for sustaining the program itself. The most important thing in our world has been our facilitator group and the nurturing of that group. They really are the face and champion this throughout the organization. Important to have the health system aligned with this work. So if you're just providing skills training and the health system doesn't care about patient experience or communication for providers, this isn't going to work. We happen to have health system goals and incentives that align with this so that everyone is looking at this across the system and it feels aligned. It feels like leadership cares about this. Balanced approach to improving the system we work in while improving individual skills. So if you just work on communication and people are drowning in their work and can't actually take the time to communicate, this won't work very well. And then having strong administrative support and data tracking for the program, and then messaging and advertising are really important for us where our program is not mandatory. For sustaining the skills, offering a lot of things that help people to follow up and do more. The first course is really just the beginning, and you can really expect people to walk away with 1 or 2 new things that they will do. And it's in the follow-up work that people begin to really dig in and learn more and commit to more. And as I mentioned before, having leaders who are committed in the clinical areas really does help this stay afloat as people go out and do their work. In our next steps, we have a number of things we're working on. I'll say one is creating resources that people can access outside of the course, so a communication cliff notes kind of a presentation where people can just go and find quick tips. We're giving away the Communication RX book that was written by the Academy's leaders, Calvin Chow and Laura Cooley. Really also extending our work to bridging with some of the work on diversity, equity, inclusion. How do we build teams across differences and microaggressions that happen in our clinical environment? And I'll end my presentation before opening for questions with a quote, which is that there is a direct link between the quality of your communication and the quality of your life. And for me, this has brought so much more fulfillment to the quality of life, both at work and personally. And so I am a firm believer in this work. And now I will open for any questions that folks have.
It looks like Gail wanted to know the name of the book. She referred to Communication RX, and this is Rachel, and I added the link there in the chat box if anybody's interested.
And then for Rachel, would you like me to just draw questions off the chat?
Yeah.
Okay, great. So August asked about nurturing the facilitator group. So I think we do some facilitator development. We bring the group together once a month to meet and connect, and really have worked on just building, I think, relationship. Our facilitators all work and co-facilitate together, so we don't keep one dyad together. They mix and have really gotten to know each other in that way as friends in addition to as co-facilitators. I think anything we can do, one thing we do is we reimburse them for their time for the day-long courses and the hours they spend in the boosters. And so that is, of course, helpful. But I think the more meaningful part is them feeling really connected to a community of like-minded individuals. And that piece has brought all of us a lot of fulfillment, I'd say. Kind of the concept of just having a community at work, a professional home within a much larger workplace has been very, very effective.
And Diane, I'll note one question that Deb had. She asked, is what else better than anything else? Is that something that you could speak to?
Yes. So the teaching of what else working more effectively than anything else is really because what else assumes that the person will have more to say or ask rather than anything else, which sometimes can be perceived as a polite ending to a conversation. And so people are much more likely, patients are much more likely to give you what they're thinking when you say what else than when you say anything else. Are there other questions? what the 100 microskills taught are. So it was 100 participants taught in microskills, not 100 microskills themselves. The microskills were listed on one of the slides. So conflict, feedback, breaking bad news, building team, and then the microaggressions skills are some of the types of things that we teach in the boosters.
And there was a question about the curriculum, and I would be glad to share information about the curriculum and resources in the follow-up email that you will receive with the recording of this webinar and PowerPoint slides. And in the interest of everybody's time, we're at the hour now, so I'll go ahead and conclude here. And I'd like to thank you, Diane, for leading such an informative webinar. Thank you to everybody for joining and engaging, and you'll be receiving an email from us soon with further information.
Thank you.